Hello, everyone. Welcome to the IBQ webinar today. We have the webinar about surgical site infection updates by our guest speaker, Dr. Saad Khan. He is a regional manager for infection control and prevention department. Also, he has a certificated diploma in infectious disease. He has experience 16 years in infection control. He has a lot of certifications such as CIC and CBHQ and CLSSPB. Welcome, Dr. Saad. The floor is yours. Hello, Dr. Saad. We cannot hear you.
Hi. Can you hear me, Dr. Tabrika?
Yes, now yes.
Okay, sorry, my mic was on mute. Hello, everyone. I'm Dr. Saad, and thank you, Mr. Tabrika, for the introduction. As you all know, today is a very important topic for discussion. We are carrying forward, which is surgical site infection. We are going to have 25 slides around, and I'll take around 35 minutes to present my presentation today. And we'll be in the end, we'll be discussing few updates from CDC and NHS and National Healthcare Surveillance Network. So we'll quickly start with our Dr. Tabrika. You have to give me rights to host so that I can share my screen.
Okay, Doctor, go ahead.
So can we all
we can see the slide.
I hope you can see my slides and it's moving.
Yes, we can see, Doctor.
Okay. Okay, so let's start with our topic today. It's one of the very important topic, and as you all know, surgical site infection is one of the most important surveillance topic of healthcare associated infections. Surgical site infections itself, it carries a lot of burden of over expenses and long length of stay, which is bothering us for past many decades, ever since we started to operate patients on. So surgical site important, as I said, it's a very important infection prevention control topic and issue for healthcare settings. Today's objective for of this presentation is to discuss and to increase awareness amongst our colleagues about the risk associated with the surgical site infection and to promote the best practices. How can we reduce the incidences and spread of this? And in the end, as I said, earlier, that we will be looking into some of the updates regarding the surgical site infections guidelines in controlling the spread of infections and strategies. We'll be discussing how to identify and respond to them accordingly. So the background of surgical site infection is quite interesting, and it's makes a lot of sense because this has been consistently been identified as a complication of surgical care. Whenever we operate a patient, they found out that there are patients are developing infections, and then there was a time in 1840s, when they introduced hand hygiene. With the evolution theory of germs in 1860, they have studied some patterns, and then they come up with the concepts of antisepsis in 1870s. And then they introduced the antiseptics inside the operation theater, operating rooms, where they were performing the surgeries in early 19th century. And then in 1960s, around late 1960s, they could able to develop antibiotics. But first antibiotic, penicillin, was discovered in the World War II, actually. So that was the find of World War II, and they call it the invention of the 20th century, by the way. So that was the revolution in terms of management of patients with the infections in 1960s after the World War II. And then surgical site infection, alone it identified as, most responsible for the post-operative hospital stays. And then we found out, then we have learned that the cost of managing these patients are extremely huge. So definitely there has to be some methodology which people have identified and developed to reduce this kind of incidences. And then to date, we are still fighting amongst ourselves to minimize the effects of surgical site infection. And although none of the organization have claimed so far that they have been able to prevent surgical site infections, from its core, because a lot of factors are involved. Multifactorial is humans itself is a one big factor because of which we are unable to minimize the effects of surgical site infection in the surgical care. So as I said, it's multifactorial. It's a result of complex interaction between the microbial contamination of the surgical site, local environmental factors which causes contamination, and the definitely efficiency of the host response, which matters in minimizing the infection, subsiding the infection, and fighting against the infection. Basic principle of surgical site infection is probably the infection which is determined by the interactions of 4 clinical variables, which is the core, the inoculum of the bacteria, which develops at the site of infections. Then the virulence of the bacteria is very important factor. How good the bacteria is to develop infection. Adjuvanted effects of the microenvironment of the wound that enhance microbial virulence. And then efficiency of the host defense. If host defense is weak, definitely patient will develop surgical site infection. If host defense is very good, then patient can fight surgical site infection, and we can avoid that. So these are the basic 4 clinical variables which play a part in the pathogenesis of the surgical site infections. Now, there are different types of wound. Before we go deep inside the discussion of surgical site infection, we all should have a very good clarity, and it's a very common topic of exam also, the types of wound. So classification and is very important of the surgical site wound infections, or before even we go for the surgery, we have to have a very clear orientation that what type of patients we are dealing with, what type of wounds patients will have if he will develop, and what type of surgeries we are performing. And based on that, we can predict the outcome of the patient. So this definition is this classification is very important for every one of us to understand. First is class 1 clean wound. As you can see, are those wounds in which no inflammation was encountered. So no contaminated spaces were encountered, and the wound was primarily closed and drained if necessarily with closed drains. So this is the classification or the definition of the class 1 clean wounds. Second class is clean contaminated wounds, which are respiratory, urinary, gastrointestinal, genital tracts were entered under controlled conditions and without unusual contamination. A minor break in class 1 wounds will be classified as clean contaminated or class 2 wounds. That surgeon usually identified at the time of the surgery. When they perform surgery, then they can identify that this patient might develop a class 2 or clean contaminated wounds post-operatively. So accordingly, we have to take care of those patients. Class 3 or contaminated wounds are those which gross spillage from the gastrointestinal tracts, entry into the genitourinary or biliary tracts in the presence of infected urine or bile, or a major break into the surgical technique may have occurred. Incision in which acute and non-purulent inflammation was present and are also included in this class, right? So it's as clearly mentioned that this type of wounds are clearly contaminated wounds. Then we have another one, the 4th class. The dirty and infected wounds are those with retained devitalized tissue, foreign body, fecal contamination, or delayed treatment from a dirty source. A perforated viscus may have been encountered. A wound with an acute bacterial inflammation with pus encountered during the operation is also included in this class. While many class 4 cases have an acute infection at the time of operations, that they need to be classified as PATUs, infection present at the time of the surgery. These operations are still counted in overall surveillance program, but the identification of PATUs will make exceptions for these infections more likely to occur when the overall performance of the facility is compiled. Now, ASA is a classification, another type of classification, which is very important to predict the outcome of the patient who are going for the surgery. So this classification, they always, it's a part of our pre-op evaluation. When anesthesia people, they evaluate the patient and they predict the patient outcome. So they give the score of ASA from 1 to 6, and ASA 1, as you can see, the description of the classification of ASA 1 is normal and healthy patients. ASA score 2, if they have, it means that patient have a mild systemic diseases. ASA 3 means patients with severe systemic diseases, and these kind of diseases can be diabetic, hypertensive, and all these kind of diseases that comes in systemic diseases. ASA class 4, patient with severe systemic diseases, that is constant threat to the life. ASA 5, equivalent to the moribund patients who is not expected to survive without the operations. ASA 6, used for the patients who declared brain dead, those whose operations are being removed for donor purposes. So ASA 6 is for basically donors, being used for the donors. So this classification is very important pre-operatively for operative evaluation to predict the outcome of the surgical wounds. Now, definition and surveillance of the surgical site infections. This is one of the most important, a core of today's topic, and that we have a different types of surgical wound. If patient goes for the surgery and he develops by any means, if he develops an infection, then we need to identify using our surveillance program that what type of infection patient has developed. So definition, there are 3 different types. One is superficial, deep, and third one is organ space. So quickly go through with the definition of superficial infection, incisional surgical site infection. It usually appears within 30 days after operative procedure. This involves only the skin and the subcutaneous tissue of the incision. And patient has at least one of the following meet one of the following criteria, which includes purulent discharge with or without laboratory confirmation from the superficial infections, organism isolated from from an aseptically obtained culture of fluid or tissue from the surgical site incision. When it says aseptically obtained, means you're not supposed to send the pus or the purulent discharge for the culture. You have to clean the wound and then send the sample for the identification of the organism. The superficial incision is deliberately opened by a surgeon and is culture positive, and the patient has at least one of the following signs and symptoms, which includes pain, tenderness, localized swelling, redness, or heat. A culture negative finding does not meet the criteria. So one of the criteria should be available if patient comes to follow up within 30 days and surgeon opens up the wound. And at the time of inspection, if they found the pain is there, tendon is there, local swelling is there, redness is there, then this is one of the criteria which has to go for the diagnosis of superficial incisional surgical site infections. Okay. And then diagnosis of the superficial site infection, superficial incisional surgical site infection by the surgeon or attending physicians or another designee, nurse practitioner, physician assistant. This is also one of the very important. If they says that the wound which they have seen or checked is most likely because they are available usually at the site of at the time of operation, so they know all the events of the surgery. So they can easily correlate with the post-operative finding, and then their justification can also go with that. So one of the criteria is very important to meet to diagnose superficial incisional surgical site infections. Now, the reporting mechanism of this, there are two specific types of superficial incisional surgical site infections: superficial incisional primary and superficial incisional secondary. Superficial incisional primary that identify in the primary incision in the patient that has an operation with one or more incisions, like median sternotomy of a coronary artery bypass grafting, and then you take the venous graft also in those patients. Secondary superficial incision infections in secondary incision, example donor site, as I said, in the coronary artery bypass grafting. So you take a vein from the leg and then you are using it for the bypass grafting. So you will have one surgery, patient will have two sites of incisions. One is the primary site is up on the chest, and secondary is on the from the site where you are taking a venous graft. Do not report stitch abscesses. This is very important to rule out superficial surgical site infections, because minimal inflammation and discharge can find to the points of suture penetrations. So, this itself does not classify for superficial surgical site infection. Do not report to localized stab wounds, pin or pin site infections. Do not report cellulitis by itself as a surgical site infection. This is another classification, but it does not come under surgical site infections. Incisional surgical site class, superficial surgical site infection that extend into the facials and muscle layers is reported as deep incisional, not as superficial. So if it goes deep down into the layers, then it will be classified as deep, not as superficial. Do not report circumcision infections as an operative superficial site infections. Burn wounds infections are reported elsewhere, but not as superficial surgical site infections. So this is very important for every one of you to remember these criteria. These what should be included into the when you are when you are doing the surveillance of the surgical site infections, to be included into the superficial surgical site infections, and what are not to be included into this report when you are doing the surveillance of superficial surgical site infections. Now, next is for deep soft tissue incisions. If these type of patients who develop deep surgical site infections, they usually present within 90 or within 30 or 90 days after the operative procedure, and it involves the soft tissue of the incision, which is like facial and the muscle layer, as I said earlier. And the patient should meet one of the criteria mentioned below, like the purulent discharge from the deep incisions, deep incision that is spontaneously dehisced and it deliberately opened by a surgeon and is culture positive. And patient should have one of the sign. Temperature should be more than 38 degrees centigrade, localized pain and tenderness should be there to classify this as a deep surgical site infections. Culture negative definitely will not meet the criteria, and abscess and other evidences of the infection involving the deep incision that is found on the direct examination during an invasive procedure or by histopathological examinations for the imaging testing. So this is also one of the criteria. And then diagnosis of the deep by a surgeon itself, as we discussed in for the superficial surgical site infection, that because the surgeon and the assistants and the nurse practitioner, physician assistants, they are there at the time of surgery and they know all the events of the surgery, so they can easily correlate whatever happened during the surgery, and they can predict the outcome. And if outcome meets the criteria, then they don't need a laboratory evidence to diagnose it as a deep surgical site infection. They can easily say it, and we have to go with that. So the reporting of deep incisional surgical site infections, there are two types. First is deep incisional primary, and then deep incisional secondary. Deep incisional primary, that is identified in a primary incision with a multiple incision may exist, median sternotomy, incision for the coronary artery bypass grafting, and then again or the secondary incision where you take the from where you take the venous graft, and we call it as a donor site. So that's also considered as a deep incisional secondary. Infection involving both the superficial and the deep site should be classified as deep. Whereas in the previous example, we have said that if superficial infection goes down into the deep layer, then it will be labeled as deep incisional. Infections involving superficial incisional, deep incisional, and organs space should be classified as deep. The attending physicians is interpreted to mean surgeon, infectious disease specialist, other physicians on the case, emergency physicians, and physician designees. They can interpret these kinds of wound easily without having the laboratory diagnosis. Now, for the sake of the surveillance, there are some surgeries. We took the slide directly from the CDC and NHSN. This is for your understanding and for all the aspirants who are going for the exam. This is one of the very important slide for you guys to memorize, that what are the surgeries or patients going for the surgeries usually develop superficial surgical site infection, and what are the patients who develop usually comes back to you as deep surgical site infection. So within the 30 days, and then for those patients, you have to do the surveillance accordingly. 30-day surveillance you have to do for all abdominal aortic aneurysm repairs, limb amputations, appendicectomy, shunt of dialysis. And you can see there is a list of surgeries for which you have to do 30-day surveillance to properly identify them as superficial or deep surgical site infections. For 90-day surveillance program, you have to continue your surveillance program for all the breast surgeries, cardiac and coronary artery surgeries, craniotomies, herniorrhaphies, peripheral vascular surgeries. Usually we don't consider peripheral vascular surgery as a deep site infections, but definitely you have to consider that. I have seen many cases, they were ignored for the peripheral vascular surgery cases. Anyhow, so this is one of the very important slide where you have to consider to continue the surveillance for 30 days, and for which surgeries you have to continue your surveillance for 90 days, and how you can differentiate between superficial, for which surgeries you need to consider as a superficial, and for which you have to consider deep.
Dr. Saad?
Yeah.
If you can a little slow down, because they want to understand more.
Okay, I can understand.
Okay.
Okay.
Thank you.
Thank you. Now, third classification of surgical site infection is organ space. This kind of patient or this kind of infection occur within or 90 days after the operative procedure, and this involves any part of the body, including the skin, fascia, muscle, that is open and manipulated during the operative procedure. And this meets at least one of the criteria which is given below, as we have discussed earlier also. Patient should have a prurulent discharge. Patient should have a prurulent discharge from the drain that is placed into the space organ spaces. The organism isolated from the aseptically obtained culture of the fluid or tissue within the organ spaces. An abscess that is evident of infection involving organ spaces that is found in direct examination during an invasive procedures, or by histopathological examinations, or in imaging testings. Again, the diagnosis directly by the surgeon and his team members will be considered as a diagnosis itself, without the laboratory investigations. So that is very important. Now, reporting instructions for deep and organ space surgical site infections involve any part of the body, as I said, but excluding the skin incisions, fascia, or muscle that is manipulated during the operative procedures. Criteria of these infections of these body site must be met in addition to the organ sites surgical site infection criteria. If a patient has an infection of organ space being operated, and the surgical incision was closed primarily, and a subsequent continuation of this infection types during the remainder of the surveillance period is considered as organ space surgical site infection if the criteria meets. Occasionally, the organ space surgical site infections drain through incisions and is considered as a complication of the incision. So that's why we have to consider this as a deep incisional surgical site infections. Mediastinitis after cardiac surgery as a mediastinal surgical site infection, not as a bone surgical site infection. If meningitis or a brain abscess are present together after the operations, so we have to report it as an intracranial infection. CSF shunt infections as meningitis surgical site infection if it has occurred within 90 days of the placement. If later or after manipulation, then it will not be considered as surgical site infection. Means when you insert it and patient developed the meningitis, then it will, and patient presented within 90 days, then it will be considered as a surgical site infection. If present later than 90 days, or if manipulation has been done of the shunt, or someone tried to access the shunt, then it should not be considered as surgical site infection. Spinal abscesses with meningitis as meningitis surgical site infections following spinal surgeries, and again, so attending physician is interpreted to mean they will report this to the infectious diseases and other physicians who are involving in these cases. Now, these are the organ site or organ space surgical site infections which has been identified or defined by National Healthcare Surveillance. These are the, if patient develop post-operative infection of these types, then you will call them as organ space or surgical site infections. So osteomyelitis, breast sepsis, myocarditis, pericarditis, disc space surgeries, mesh surgeries, endometriitis, GI tract surgeries, hepatitis, mediastinitis, sinusitis. You can see the most common type of surgeries. You can find it over here, which are the common sites for organ space or surgical site infections as defined by NHSM. This slide is also very important for all the aspirants who are going for exams, so that you don't have to memorize it, but just understand the concept. And then, if you can memorize them, that if someone is being operated on these kind of sites, then they can develop surgical site infection. So easily rule out the other trick questions. Now, how can we prevent surgical site infections? There are different techniques that have been used to reduce the bacteria at the surgical site by using the antiseptic scrubs, by offering the patients complete body wash, showers pre-operatively before the night before this 2 days before the surgery and the night before the surgery. These are the techniques which we can use to prevent we can reduce the harboring of the bacteria at the skin, and patient will come to us prepared with the lesser load of the bacteria. So skin preparation using isopropyl alcohols, providing iodine, chlorhexidine. Hair removal is one of the very important topic. It's a very vast topic, by the way, itself alone. Hair removal is one of the very crucial or common factor for surgical site infections. We must not shave the patient prior to the surgery, and if we are offering we do not have a clipper, we do not have clipper services available, so we should advise the patient to shave the hair at least 48 hours before the surgery, not within the 48. If patient has performed shave to remove the hair from the surgical site or the incisional site, then we must not perform surgery. We should try to delay the surgery, and we have to prepare the patient properly. Otherwise, on table, in case of emergency, we have to use the clipper to remove the hairs. We should not shave. We should not use the blade to shave the hairs from the patient's skin or from the incisional sites. Circular wound protectors, plastic adherent drapes, cyanoacrylate skin sealants. You can see one of the. I tried to put some pictures around it. So you can see, these kind of sealants, they're usually surgeons use to prevent the contact with the skin and the wounds or those operating sites. So this sealants they can use to prevent the exposure of the bacteria with the operative sites, and then this way we can prevent the surgical site infections. Surgical scrub of hands and forearms for 2 to 6 minutes is one of the very important and regularly technique to prevent the surgical site infections, which can reduce the bacteria from the skin of the operator or the surgeon and the assistants of the surgeon. So this is for them. Sterile drapes and sterile barriers. Laminar flow of the operation theater is very important factor. If it is not laminar, if laminar flow is not correct, air flow is correct. If it is not laminar, then it can cause, it can affect the bacterial incisional site, and it can harbor, patient can harbor bacteria. Sterilization of surgical instruments is one of the crucial. Again, it's a complete topic which we have covered in the last webinar. I could not able to attend, but I saw the slides and I read about it. So sterilization of surgical instruments is very important. Flash sterilization is one of the very important topic where the loaner instruments, or if one of the instruments which surgeon requires during the surgery, so how it should be used, how should be sterilized using the temperature controls and the proper methodology before use of the loaner instruments. Traffic control, which is very commonly ignored during the surgical settings. When patient is being operated, you have commonly found that doors are being left open of the operation theaters, unnecessary movement within and outside the operation theater. Um, uh, More patients involved into the care of the surgical patients inside the operation theater, and then they come in and go out, and which creates a turbulence in the airflows itself, which can cause exposure to the patients of certain bacteria. So traffic control is very important. Door should always be closed. Unnecessary movement inside and outside the OR is to be avoided during the surgical timings. This is one of the important element to reduce the bacterial exposure to the surgical sites. Then delayed primary or secondary closure. This is very important. You have to clearly identify the types of wound you're dealing with. The massive disruption of the colon from the high velocity gunshot wounds, severe pancreatic abscesses. And these are some examples, where you have to where you have to consider a delayed primary or the secondary closure. If you try to close the dirty wounds, with the primary closure, patient will definitely develop an infection, and then you will end up into long hospital stay, and the cost of the management of such patients and wounds will be very high. Use of bed dressing and delay closure may be feasible for the 4th and 5th day of the operation of such kind of patients. Is very important element to prevent these kind of complications. Another prevention methodology is negative pressure wound therapy. I'm sure most of you have seen, patient with the suction attached with the dressing. This method entails the placement of the polyester foam over the wound, and the coverage of the foam and the adjacent skin with the transparent plastic adhesive tape. Opsite, usually we call it. The trade name of that tape is Opsite. So what we do, we put a polyester foam, we put a drain, we put a suction drain, we put a polyester foam over the wound, which covers the wound and the skin around it. And then we put Opsite on top of it, and then we turn on the suction device. So it tries to, continuously suck the wound, the all kind of collections, pus, bacteria, all kind of secretion from the wound. It tries to collect, and it goes into the foam, and then you have to regularly change the dressing. And this has, by the way, so far one of the very best technique have been identified. It cures a very complicated wound. I've seen a lot of patients, which were in past not being cured using the conventional method of wound management, but with the negative pressure wound therapy, they have shown good results and recovered very fast, by the way. But one of the very important point to consider over here, that negative pressure wound therapy sometimes does not eliminate the need of local debridement for non-viable tissues. So it should not be applied on in those wounds where the tissue is not viable. So this technique is only for the viable tissue if you have it. Pressure irrigation is one of the techniques to prevent surgical site infection. Use of infection prevention with the pressure irrigation of open wounds before closure uh, as an adjunctive therapy of open wound which are not primarily closed. Positive pressure irrigation presumably disrupt the fibrin film and remove the bacterial contaminations that that are being entrapped into the fibrin fibers. So this helps also to keep the wound clean. Antibiotics to being used as the preventive measures. Most commonly misunderstood technique to prevent surgical site infection, by the way. Most of the surgeons, they are advising empirical therapies, and they are continuing this empirical therapies for more than the recommended periods. And sometimes you have seen that they are using antibiotics which are not recommended for as a empirical therapy for to prevent surgical site infections. So this is one of the very important. The antimicrobial stewardship program is very important over here to prevent surgical site infections, where surgeons are using empirical antibiotics for empirical services, empirical therapies, which are not indicated to prevent surgical site infections. So prevent surgical site infections, antibiotic usually should be given within the 30 minutes of window. This is also very critical topic to discuss because communication is a very important element over here when nurses usually in our practice, I have seen 99% of the time that nurses preoperatively administer antibiotics. And actually, preoperative antibiotic is a job of anesthetist to give. When patient is in the preoperative bay, this is the time where anesthetist has to evaluate the patient, and then they know that when patient will be under the influence of the anesthesia, and they know the approximate timing of the incision along with the surgeon. So they should monitor this rather than what is happening, that our nurses has been given this task preoperatively, and usually patient receive antibiotic in the wards, which is wrong practice. Patient should receive the antibiotics in the operative bay within 60 minutes window, except for the vancomycin and fluoroquinolones, which should be given 2 hours or 120 minutes window between the 120 minutes window. So this is one of the very important element for which I always advise to have a proper data collection to be done, and to see the practices. If this factor has not been considered properly and not been taken care properly, you will never be able to understand why patient is being develop infections or not developing infection, and you can control the misuse of antibiotics. And this is the point where we have to change our practices also. So selection of the antibiotics, timing of the antibiotic is very important element. Correct antibiotics to be used as an empirical therapy to prevent surgical site infections, and it should be given within the correct window of the incision, before the incision. And discontinuation of the empirical therapies after 24 hours, other than the coronary artery bypass grafting, where you can continue empirical therapies for up to 48 hours, and then you have to stop the empirical therapies. This is one of the very important factor to consider. Then enhancements of the host, during surgery, we should consider giving supplemental oxygen to the patients. We have to monitor the patient temperatures to hypothermia, which is one of the recognized complication of the laparotomy and thoracotomy procedures. This patient, if patient is going for laparotomy and thoracotomy, they are more prone to have surgical site infection, and temperature controls plays a very role in these types of patients. Hyperglycemia, which is one of the common factor again. If patient is under the influence of some drug, influence of diabetes, then especially those kind of patient to be monitored properly, and we need to make sure that patient do not develop into go into hyperglycemic state, which can cause put patient into the condition where a patient can develop surgical site infection if any other factor has been ignored in the surgical care. So the management of surgical site infection is straightforward. Open and drain the incisions. Whenever you have a patient of surgical site infection of any type, superficial, deep, or organ space, you have to open them, drain the incisions, debride the fibrous debris and the necrotic tissues, remove the foreign bodies, implant antimicrobial management as needed. Implement antimicrobial management as needed as a therapeutic in the therapeutic doses, and then manage them as an open wound. So do not try to close infected wounds and treat them as a secondary wounds, and consider the delay management of these of any types of surgical site infections. And the last topic of today's discussion is the update. So there are around 16 updates which CDC NHSN has done, and I just copy paste, by the way, of these updates into the slides, and we'll quickly go through with that. I would recommend all the aspirants of CIC, and or if you are going for any other exam, or all my participants, to please open and read these updates by yourself one time. I'm sure you guys have gone through with the chapters. So just open these updates, it, and also policies. This is one of the requirement of the accreditation authorities these days. I'm not sure where you all are working, but this is one of the important, should include all these updates in your policies and procedures. Educate your staff, educate the doctors, educate the nurses, and then try to change your practices accordingly if being affected. So there's a chapter number 2 where updates has been made to in the examples and the tables which they have provided. They have removed the table number 1 from the chapter chapter number 2, referencing the period of the endocarditis. In chapter number 4 of the bloodstream infections, they have provided the clarification on blood specimen collection techniques, and then they have to provide the clarification on the for the port of bloodstream infections, which is also healthcare associated, which is a part of healthcare associated infections surveillance. So they have provided clarification on that topic, and they have also provided the clarification on mucosal barrier injury for the laboratory confirmed bloodstream diagnosis. And chapter 6 of pneumonia clarification they have done. They have changed the figures. Initially I thought to attach the figures, but then I removed it, because you have to read the whole chapter so that you can understand those figures, and then you can understand that what changes they have done they have made it more readable, and they have made it more clear, or the information which they have mentioned in the text, it's now relevant to the pictures also. Chapter number 7, they have made changes, and they have updated that also regarding to the Foley's and catheter devices for the consistency purposes. Chapter number 9, surgical site infections. They have provided clarification on the details of the surveillance period, and regarding the patient return to the OR in non-NHS and operative procedures, deep incident criteria, and surgical site infection open and space criteria C. They have made some changes over there. Chapter number 10 for ventilator associated events, and they have added an appendix in that. Chapter number 5, there was no changes. Chapter number 11, the ventilator associated events. So they have added these antivirals into the appendix. And chapter number 14, antimicrobial use and the resistance additions they have done for antimicrobial use. That the targeted assessments of antimicrobial stewardship is added into the chapter. For the resistance, they have added a section for standardized resistant infection ratios and pathogen specific standardized infection ratios, the phenotypes, and the new appendices for these pathogen specific and standard resistant infection ratios. They have added the new appendices for that. For antimicrobial use options, they have clarified the eligibility of reporting, and they have changed the wording from step down neonatal nursery to special care nursery. This is more not critical, but one of the important. Now they have changed the terminology, which we should also use in our practices. And then chapter 15, 2 or 4 location were added into the from the previous updates to they have added into the new update also. 16, the key they clarify the key term for the calendar days. And 17, they have added the endo criteria to clarify each element of the endo site which we are using for classification. So that's all from my side. And it's it's still I have not covered most of the thing, because already I've taken 45 minutes and 25 slides, 50 minutes almost. It's a very lengthy topic. 1 hour is not enough to cover all the aspects of surgical site infection, but I just try to cover the basic concept of surgical site infections, wound classification, ASA classification, what are the different types of wounds, surveillance periods, management of the surgical site wounds, and different prevention methodologies to prevent surgical site infection, and updates. So this was the core of today's discussion. Again, this is not enough for all of you. I have 26 participants today. I would advise all 26 participants to please go back, read yourself the surgical site infections. This is one of the very important topic, not only for the exam purposes, but if you are working as a practitioners, you need to identify the 2 or 3 or 4 or 5 most commonly performed surgeries in your facilities, include them in your surveillance program, start with them, and see how your operation theaters are performing, how your surgeons are performing, how you are managing pre and post operatively your patients in the surgical care, and look for the positive outcomes. So this is one of the important, as I said in the first slide, this is surgical site infection. Ever since we have started performing the surgeries to date, none of the organization have claimed that we have successfully achieved the target or the benchmark of 0 surgical site infection. No one can claim that. So, and this causes a burden, huge burden on the service provider itself, if and medical legal issues also. A lot of hospitals, organizations are under the medical legal issues. And if patient is cash, if there we most of the time we are not into the medical legal issues, but patient has to pay a lot from its own pocket in terms of length of stays, in terms of the care management, even if he's not admitted into the hospital, post-operative care if he has to provide, or in terms of insurance, if patient even is insured, someone is paying for this, either insurance or cash. So we are losing a lot of money just because we don't take care of pre-operatively, intraoperatively, and post-operatively. So that's all from us. Thank you all.
Thank you, Dr. Saad, for the informative presentation. We have a few questions regarding the SSI Updates 2022. There was published a recommendation by SHIA and APIC and CDC. And there was a question about what is the new update about antibiotic administration. Do you have an idea about this?
No, Dr. Tabrika, if I would like you to add on that, I would not be able to address that actually.
Okay, now regarding the new updates from Shia, actually the antibiotic timing, they said it should be stopped before the closure of the surgical wound. We know that it should be the previous guidelines. They mentioned that it is within 24 hours should be discontinued, and for the heart surgery within 48 hours. But now, according to the updates, we have to discontinue after the closure of the surgical wound.
Okay.
I think we need, yeah, this is some of the updates, and
Okay.
they shifted.
Okay, that's
Actually,
very
this
good.
is the only, yeah, this is the only major change in the
In the surgery and the antimicrobial stewardship.
yeah, it's part of the surgical updates by Shia 2022. This is the new guidelines. They said
Okay.
about the changing of antibiotic administration.
Okay. So
Other questions?
one question is there, is the post pilonidal infection got infected can be classified? See, yes, it can. Again, this also can be classified as surgical site infection. You have to meet all the criterias, and incision site, sorry, the SSI as defined in an infection that occur within 30 days after the surgery at the incision site, or within 1 year, if an implant has been placed there. I'm just little bit exaggerating it, but yes, it can be considered as surgical site infection. Yeah, someone said to share PPT. Yes, we'll do it. Okay, so okay, so there was only one question in the messages. Yeah.
Okay, if anyone has a question, please share. Otherwise, we can end the meeting. And Doctor, we can have an additional slide about the new article from Shia. It can be like added to the presentation, and we can share it in the group. If you don't.
Absolutely, Doctor, we can do that. And thank you for adding the comments.
Thank you
you,
so
everyone.
much.
Thank you,
Thank you.
everyone, for the participation.
I have a question, sorry.
Yes, please.
Hello, this is Amina from Infection Control from Bahrain. Thank you so much, Doctor, for your informative session. I have an inquiry regarding the under-reporting because some of the surgeons, they will not report for us any surgical site infection. Or even if we have events and we try, like we have discussion with the surgeon, sometimes they will be very offensive. And they will say this is batos, or this is already microorganism, it's already there, it was. So how can we how can we able
come
to
again?
overcome
What's your name? What's your name?
I am Amina. I am infection
Amina.
control
Okay,
from
Miss Amina.
Bahrain.
Miss Amina. Yeah, Miss Amina, it's a very, 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 very important topic or question you have asked, actually. And everyone should ask this question, by the way. I was expecting this question. You see, this is one of the common problem, and I think Dr. Tabrika and will also agree with me. This is a global issue, by the way. Global issue. When I say global issue, this is not only your problem or in your clinic or in your hospital, wherever you are working. This is a problem in America. This is a problem in Europe. This is a problem in Canada, Australia, Middle East. Everywhere you go, you work, you will find doctors, surgeon. First of all, let's go one by one. Surgeons, they feel afraid, and most of the time it's a personal. They take it as a personal issue. I'm just trying to clear the air so that you can understand their aspect also and how you deal with the situation. So most of the time, the first personal element comes in when it comes to the surgical site infection. Surgeons, operative team, they think that if they report surgical site infection, it will be used against them. So it's a taboo, by the way. they, first of all, they think that this is very bad if they report that they are the bad surgeon, their patients are getting complicated. So they consider this as an ethical issue. So this is the one of the issue for which you have to do education of your quality department, your hospital management leadership. They should they should do some sort of education sessions with them. You have to do some confidence building major activities in your hospital, so that they feel they feel confident enough to report these kind of infections, and you have to take out the element of fear from them. So unless they will have this element of fear within themselves, that if they report, then they will be held accountable for those infections, they will never be able to start reporting it. This is one of the very common issue, which is definitely, it's not easy to deal. Even if you do education training sessions, this will take time to resolve. Yes, now come to the point, how you can encounter, or how can you improve this. So one element, as I said, you can do education of your doctors, involving your hospital management leadership, hospital director, medical director, quality department. Everyone can come in, and they can do multiple session, different types of session, to educate them and to take out the fear from them. That's one thing. Second thing, when you educate them not only on surgical site infection related to their practices, educate them on all the other elements which we have discussed today. That surgical site infection is multifactorial, starting from the preoperative counseling of the patient. When patient comes to the OPD, how important is it to educate them on the preoperative showers, preoperative bathing? How important is it to educate them on hair preparation of the skin, hair removals? Then your pharmacy team, they should regularly do the antimicrobial analysis. They have to perform, they have to develop antibiograms and annual antimicrobial stewardship updates. They have to continuously educate their doctors, provide them evidence-based data, so that they can learn from that, and then regular checks on your environmental services, your HVAC services. So that is very important. If you have any findings into that, put them in front of them, that patient is not developing infection because of you. Patient is developing infection because of FMS issues. You know what I mean? If your laminar flow is not working, so they will feel confident. Yes, this is not me. This is because of some other services also. It's multifactorial. So be very transparent. Be very clear with them. Take up all the issues. Use your environmental rounds. Use your different source of information to and bring them in different committees, different platforms, different meetings, so that you address them. And don't always talk to them about a surgical site infection related to surgical practices. There it is multifactorial, and we have to cover all these aspects when we talk about surgical site infections. This is one thing. Next thing, what you can do from your side, put a Swiss cheese method. Swiss cheese method, Ms. Tabrika, I'm sure you know this, that you have to put multiple barriers. You have a checklist, you have a surgical site infection, surgical safety checklist available. Use that. You have a surgical site infection checklist. Use that also. Do the proper medical audits, be a part of it. If it is checked, your medical record audit is being done for surgical patients properly, and what information you're getting from them, and use this information to improve services. And then post-operatively, you can use post-discharge surveillance processes. As we have seen, 30-day surveillance, 90-day surveillance process. If you have a proper organization, you have a surgical department, you can your secretary or the case manager can call the patient, and they can follow up with the patient to find out what is happening, so that you can eliminate the dependency of the reporting of surgical site infection from the surgeons. So you have another person who is monitoring these cases besides surgeons. So the surgeons can stop hiding these patients. You can use the questionnaires, patient questionnaires, for the patient, for post-operative follow-ups. So use those post-operative follow-ups for whenever you have a patient in your facility on follow-up, give them a small questionnaire for five question, small, very basic, simple question terminologies. Ask them how you are doing post-operatively, how is the wound post-operatively, did you develop fever, are you taking any antibiotics, did your surgeon open the wound, Is there any discharge from the wound? Simple questionnaires give to the post-operative patients. They will give you the information, and then if there is a red flag in the questionnaire, any of the question answered yes, go back and open the file, review the case, and try to diagnose this case or rule out the surgical site infection. Then your procedure, your post-operative procedures, or the procedure rooms, wherever you are changing the dressing, you can educate your nurses how to identify the post-operative procedure infections whenever they have a patient for dressing change, or if surgeons are sending their patients. Ideally, first dressing is to be changed by surgeon himself. Sterile dressings to be changed by the surgeon itself. If surgeons are not routinely following this, then nurses to be trained that if they are changing the first sterile dressing, what are the things they should look for, and if they identify any of the element of the surgical site infection, they should report to you, so that you can start the investigation to identify or to rule out surgical site infection. So these are some of the, although I have discussed a lot, but these are some of the techniques, methodologies, some of the methods you can use, not only to eliminate the dependency on the surgeons. Actually, I try to answer, Miss Amina. I hope makes sense to you.
Yes, yes, indeed. Thank you so much, Doctor.
There's a question from Mr. Das that are there any measures I can take home to prevent a surgical site infection after surgery? Yes, your counseling is one of the very important, starting from the patient counseling, how they have to take care of the wound. So give a questionnaire or the pamphlet, make a pamphlet in different languages to according to the population you are catering. Make a post-operative counseling or the education material for the patient, what they have to do at home if they develop any kind of symptom, how they have to report back to the facility or to the surgeon, how they can avoid contamination of the wound at home if by accident dressing comes out, and what are the things they have to be taken care of at home. So these kind of patient education material you can develop, and you can give to all your surgical patients, so that they can take care of themselves at home also. Can we, Ms. Dani asked, can we include one team member or to reduce surgical site infection in the facility so that they can communicate with other team members and encourage them to participate? Absolutely, yes, you can do that. In my hospital, we have one nurse completely dedicated as a wound care nurse. So her job is to make rounds in inpatient services, and she goes and check all the wounds herself, and she's a part of SSI team. She reports also, and she checks in the surgical OPDs also with all the nurse assistants and with the surgeons, how many post-operative patients they have, what were the condition of the wound, and different kind of methods we have tried to implement to minimize this or to control this effect. Post-operative surveillance is important, as we are doing these in this hospital. Yes, Miss Akhtar, Miss Anis Akhtar, you're doing the right thing. And is there any other questions? So it would be best option first to educate them and audit them. Sir, audit and educate don't. Yes, it should go simultaneously. Audit is one thing which you have to do for all kind of patient, but in terms of when we are talking about surgical patients, so that audit is something else. Your surveillance is something else which you have to do on most commonly performed procedure or most common diagnosis of your facility. That audit is that surveillance is different than audit, and definitely education, which is a continuous activity regardless of your surgical site infection rate. You have to continuously and regularly do the education of your staff. Issue due to insurance, doctor will not report. Yes, this Miss Olga, this is of one of the very common observation. because of the insurance, doctors, they don't report because insurance, they don't cover post-operative or surgical site infections or post-operative management as yeah, as a part of a care they are providing through insurance. This is one of the factor which is, affecting insurance services a lot, and affecting the patient care also. So that's why reporting is very underestimated because of this issue. I agree with you, but definitely we have to practice, and we have to do for the betterment of the patient. Not We are not working for the betterment of the insurance services. We are not working for them as a business partners. Our primary goal is to provide care to the patients. So again, try your best to help your patients, not try to help the insurance. I'm sure you are not doing it. Your surgeons are doing it, but you should, keep up the patient safety flag up. Okay. So is there any other question?
No, Doctor, thank you so much. Thank you, everyone. Have a good night and see you in next webinar, inshallah. Thank you.
Thank you, everyone. Thank you, Mr. Breaker, for providing an opportunity.